Hello friends. Welcome back to this series of lectures on cardiology for MBBS students. In my previous lectures we have covered physiology, anatomy, investigations for heart diseases. If you have still not subscribed to this channel, this is the time that you hit the subscribe button so that you can instantly get notified of all new videos. Do not forget to like and comment once you complete the video. Today we will cover the presenting problems in cardiovascular disease. Cardiovascular diseases give rise to a relatively limited range of symptoms. Differential diagnosis depends on careful analysis of the factors that provoke symptoms. Patients may describe the same symptom in different ways based on their own perception. For example, chest pain may be described as a burning in the epigastrium. The differential diagnosis also depends on clinical findings and investigations. A close relationship between symptoms and exercise is the hallmark of heart disease. We use the New York Heart Association (NYHA) functional classification to grade disability as Class 1 no limitation during ordinary activity, Class 2 slight limitation during ordinary activity, Class 3 marked limitation of normal activities without symptoms at rest, Class 4 unable to undertake physical activity without symptoms, symptoms may be present at rest. To understand NYHA classification clearly you must know the meaning of the words limitation and ordinary activity. The word limitation means development of fatigue or palpitation or dyspnea. And ordinary activity refers to the activity that the patient was habitual of doing prior to becoming sick. For example, for a marathon runner, ordinary activity would be running for many miles, and for a housewife, it would be doing routine household work. Most important symptom of heart disease is chest pain. Chest pain is a common presentation of cardiac disease, but it can also be a manifestation of anxiety or disease of the lungs or musculoskeletal or gastrointestinal systems. Some patients describe pain as discomfort, but the significance remains the same. The most worrisome cause of chest pain is ischemic cardiac pain, also called angina. It is worrisome because angina could represent the beginning of a myocardial infarction that could lead on to a cardiac arrest and sudden death. So, it becomes important to rule out any possibility of cardiac ischemia in all patients having chest pain. What are the characteristics of ischemic cardiac pain? Several key characteristics help to distinguish cardiac pain from that of other causes. Occasionally, cardiac pain may be experienced only at the sites of radiation or in the back. It is important to note that the pain situated over the left anterior chest and radiating laterally is unlikely to be due to cardiac ischemia and may have many causes including pleural or lung disorders, musculoskeletal problems and anxiety. Character. Cardiac pain is typically dull, constricting, choking or heavy, and is usually described as squeezing, crushing, burning or aching but not sharp, stabbing, pricking or knife-like. The above sensations can also be described as breathlessness rather than chest pain. Patients often emphasize that it is a discomfort rather than a pain. They typically use characteristic hand gestures, e.g. open hand or clenched fist, when describing ischemic pain. Provocation. Typical anginal pain or stable angina occurs during exertion and not after exertion and is promptly relieved, in less than 5 minutes, by rest. Stable angina is a manifestation of stable coronary plaques that obstruct the lumen of coronary arteries greater than 70%. The pain may also be precipitated or exacerbated by emotion but tends to occur more readily during exertion, after a large meal or in a cold wind. In some of the patients with stable angina, one of the coronary artery plaques can become unstable and starts accumulating platelets. This narrows the coronaries further and leads to unstable angina or a frank myocardial infarction. In unstable angina, the chest pain occurs at lesser degrees of exertion, occurs more frequently, or persists for a longer duration than earlier episodes of angina, and we must identify and rule out acute coronary syndrome in such patients. The increase in venous return or preload induced by lying down may also be sufficient to provoke pain in vulnerable patients and is called Decubitus Angina. The provocative factors that make the chest pain less likely to be of cardiac ischemic origin include pleural or pericardial pain, which is usually described as a sharp sensation that is exacerbated by breathing, coughing or movement. Also, if the pain is associated with a specific movement like bending, stretching, turning, it is likely to be musculoskeletal in origin. Onset. The pain of myocardial infarction typically takes several minutes or even longer to develop. Similarly, angina builds up gradually in proportion to the intensity of exertion. Pain that occurs after rather than during exertion is usually musculoskeletal or psychological in origin. The pain of aortic dissection, massive pulmonary embolism or pneumothorax is usually very sudden or instantaneous in onset. Associated features. The pain is accompanied by sweating, nausea or vomiting. We must think of myocardial infarction, massive pulmonary embolism or aortic dissection. Patients with myocardial infarction or angina may present predominantly with symptoms of breathlessness, due to pulmonary congestion arising from transient ischemic LV dysfunction. That is why breathlessness is called an angina equivalent. Breathlessness may also accompany any of the respiratory causes of chest pain and can be associated with cough, wheeze or other respiratory symptoms. Classical gastrointestinal symptoms, such as esophageal reflux, esophagitis, peptic ulceration or biliary disease, may indicate non-cardiac chest pain, but effort-related indigestion is usually due to heart disease. It is important to know that in esophageal spasm, pain location is behind sternum and this spasm gets relieved by giving nitrates. This should be kept in mind while attributing relief by nitrates as a diagnostic marker for ischemic chest pain. We will now cover the differential diagnosis of chest pain. Psychological aspects of chest pain. Emotional distress is a common cause of atypical chest pain. This diagnosis should be considered if there are features of anxiety and the pain lacks a predictable relationship with exercise. However, the prospect of heart disease is a frightening experience, particularly when it has been responsible for the death of a close friend or relative. Psychological and organic features therefore often coexist. Anxiety may amplify the effects of organic disease and can create a very confusing picture. Patients who believe they are suffering from heart disease are sometimes afraid to take exercise, and this may make it difficult to establish the true effort tolerance. Assessment may also be complicated by the impact of physical deconditioning. Myocarditis and pericarditis. Pain is characteristically felt retrosternally, to the left of the sternum, or in the left or right shoulder, and typically varies in intensity with movement and the phase of respiration. The pain is usually described as sharp, and may catch the patient during inspiration, coughing or lying flat. There is occasionally a history of a prodromal viral illness. Mitral valve prolapse. Sharp left-sided chest pain that is suggestive of a musculoskeletal problem may be a feature of mitral valve prolapse. Aortic dissection. This pain is severe, sharp and tearing, is often felt in or penetrating through to the back, and is typically very abrupt in onset. The pain follows the path of the dissection. Aortic dissection is a life-threatening condition and must not be missed, and therefore threshold for investigation for dissection should be kept low. Esophageal pain. This can mimic the pain of angina very closely, is sometimes precipitated by exercise and may be relieved by nitrates. However, it is usually possible to elicit a history relating chest pain to supine posture or eating, drinking or esophageal reflux. It often radiates to the back. Bronchospasm. Patients with reversible airways obstruction, such as asthma, may describe exertional chest tightness that is relieved by rest. This may be difficult to distinguish from ischemic chest tightness. Bronchospasm may be associated with wheeze, atopy and cough. Musculoskeletal chest pain. This is a common problem that is very variable in site and intensity, but does not usually fall into any of the patterns described above. The pain may vary with posture or movement of the upper body and is sometimes accompanied by local tenderness over a rib or costal cartilage. There are numerous causes, including arthritis, costochondritis, intercostal muscle injury, and Coxsackie viral infection, also called epidemic myalgia or Bornholm disease. Many minor soft tissue injuries are related to everyday activities such as driving, manual work and sport. The differential diagnosis of peripheral or pleural chest pain includes pulmonary infarct, pneumonia, pneumothorax, malignancy, tuberculosis, and connective tissue disorders. How do we proceed with initial evaluation of suspected cardiac pain? While evaluating chest pain, the most important thing is to rule out life-threatening causes of chest pain that include acute coronary syndromes, pulmonary embolism, aortic dissection, and pneumothorax. A careful history, detailed physical examination and focused investigations help us to confirm the diagnosis. Stable angina. Effort-related chest pain is the hallmark of stable angina. The reproducibility, predictability and relationship to physical exertion, and occasionally emotion, of the chest pain are the most important features. The duration of symptoms should be noted because patients with recent onset angina are at greater risk than those with long-standing and unchanged symptoms. Physical examination is often normal but may reveal evidence of disorders. Some examples are Xanthoma indicates hyperlipidemia. Left ventricular dysfunction is suggested by dyskinetic apex beat and gallop rhythm. Signs of peripheral vascular disease are present in arterial disease. Asthma may be described as exertional chest tightness. Unrelated conditions that may exacerbate angina include anemia and thyroid disease. Stable angina is usually a symptom of coronary artery disease. It may also be a manifestation of aortic valve disease and hypertrophic cardiomyopathy. In both these conditions, left ventricle is extremely hypertrophied and even normal coronaries are unable to supply enough blood during exertion to the whole of the myocardium, producing stable angina. In patients with angina in whom a murmur is found, echocardiography should be performed. A full blood count, fasting blood glucose, lipids, thyroid function tests and a 12-lead ECG are the most important baseline investigations. Exercise testing may help to confirm the diagnosis and is also used to identify high-risk patients who require further investigation and treatment. Acute coronary syndromes. Unstable angina and myocardial infarction are two forms of acute coronary syndrome. ACS requires urgent evaluation because of a high risk of avoidable complications, such as sudden death and MI. Hemodynamic compromise suggested by hypotension, pulmonary edema, ST segment elevation or depression on ECG and elevated troponin I/ORTI are powerful indicators of short-term risk. A 12-lead ECG is mandatory and is the most useful method of initial triage. The release of markers such as creatine kinase, troponin and myoglobin is relatively slow but can help guide immediate management and treatment. If the diagnosis is unclear, patients with a suspected acute coronary syndrome should be observed in hospital. Repeated ECG recordings are valuable, particularly if obtained during an episode of pain. Plasma troponin concentrations should be measured and, if normal, repeated 3 hours after the onset of symptoms or hospital admission. New ECG changes or an elevated plasma troponin concentration confirm the diagnosis of an acute coronary syndrome. The subsequent management is: if the pain has not recurred 3 hours after the onset of symptoms, plasma high-sensitivity troponin concentrations are not elevated and there are no new ECG changes, the patient may be discharged from hospital. At this stage, an exercise test is advised to rule out underlying coronary artery disease producing stable angina, but this does not reliably exclude the future risk of MI. The second important symptom of cardiac origin is breathlessness or dyspnea. Dyspnea of cardiac origin may vary in severity from an uncomfortable awareness of breathing to a frightening sensation of fighting for breath. The sensation of dyspnea originates in the cerebral cortex. There are several causes of cardiac dyspnea. Acute left heart failure. Acute left heart failure may be triggered by a major event such as myocardial infarction in a previously healthy heart, or by a relatively minor event such as the onset of atrial fibrillation in a diseased heart. An increase in the LV diastolic pressure causes the pressure in the LA pulmonary veins and pulmonary capillaries to rise. When the hydrostatic pressure of the pulmonary capillaries exceeds the oncotic pressure of plasma, about 25 to 30 mm of mercury, fluid moves from the capillaries into alveoli. Congestion of the bronchial mucosa may cause wheeze, also called cardiac asthma. Acute pulmonary edema is a terrifying experience with the sensation of fighting for breath. Sitting upright or standing may provide some relief by helping to reduce congestion at the apices of the lungs. The patient may be unable to speak and is typically distressed, agitated, sweaty and pale. Chronic heart failure. Chronic heart failure is the most common cardiac cause of chronic dyspnea. Symptoms may first present on moderate exertion, such as walking up a steep hill, and may be described as a difficulty in catching my breath. As heart failure progresses, the dyspnea is provoked by less exertion and ultimately the patient may be breathless walking from room to room, washing, dressing or trying to hold a conversation. Other symptoms may include orthopnea. Lying down increases the venous return to the heart and provokes breathlessness. Patients may prop themselves up with pillows to prevent this. Paroxysmal nocturnal dyspnea or PND. In patients with severe heart failure, fluid shifts from the interstitial tissues of the peripheries into the circulation within 1 to 2 hours of lying down. Pulmonary edema develops, causing the patient to wake and sit upright, profoundly breathless. Cheney-Stokes respiration. This cyclical pattern of respiration is due to impaired responsiveness of the respiratory center to carbon dioxide and occurs in severe left ventricular failure. Arrhythmia. Any arrhythmia may cause breathlessness but usually does so only if the heart is structurally abnormal, such as with the onset of atrial fibrillation in a patient with mitral stenosis. Angina equivalent. Breathlessness is a common feature of angina. Patients will sometimes describe chest tightness as breathlessness. However, myocardial ischemia may also induce true breathlessness by provoking transient LV dysfunction or heart failure. When breathlessness is the dominant or sole feature of myocardial ischemia, it is known as angina equivalent. A history of chest tightness, the close correlation with exercise, and objective evidence of myocardial ischemia from stress testing may all help to establish the diagnosis. With this, we come to the end of this lecture for MBBS students on the presenting problems in cardiovascular disease. Hope you enjoyed the video. For more videos like this, do not forget to like and subscribe the channel. Do post your comments and queries related to the topic. Also, suggestions are invited for the improvement of videos in future. Have a great learning.